Dr. Benner with the Shelburne Knee Center, and this is the Shelburne Knee Center podcast. Thank you for joining us tonight. If you want to catch us on social media, you can catch us on Instagram and Twitter at the SKC Podcast. You can find us on our Shelburne Knee Center Podcast Facebook and YouTube pages, or you can email us to try to contact us at the skcpodcast@gmail.com. If you like this episode and ones that you've heard previously, please leave us a 5-star review and a comment, and make sure you follow us so you don't miss any future content. Last week, we had Femi Burke, a resident from Wright State University, on talking about total knee arthroplasty results based on area deprivation index. And an interesting discussion, an interesting study that Femi helped us work on at Shelburne Knee Center about the impact of area deprivation index, some socioeconomic factors on total knee replacement outcomes. So make sure to go check that one out, as well as all of our previous content.
And tonight we're going to be going over another Patient's Place episode, which, just a recap, the Patient's Place episodes is going to be more for the patient in mind and really to be utilized as an educational resource. And we're trying to spread around the diagnoses that we see and provide as much education as possible. And we've gone over episodes in the past that have covered osteoarthritis, knee replacements, ACLs, and meniscus tears. And tonight we're going to try to hit a little bit different of a diagnosis. We're going to discuss one of the other big ligaments in the knee. We already talked about the ACL, but tonight we're going to be talking about PCL tears. So let's jump right in. Dr. Benner, like we have in the other Patient's Place episodes, let's start with more of the signs and symptoms. When a patient sustains something like a PCL injury or PCL tear, what are the common signs and symptoms you would be anticipating that the patient would be describing to you?
One of the most important things about making the diagnosis of PCL tears is just the mechanism of injury. It's a very specific couple of mechanisms of injury that you get PCL tears, and you don't really get other types of diagnosis by that same mechanism. So there's a couple giveaways in that. The PCL tear is usually a blow to the front of the tibia, kind of right over the tibial tubercle. And if you think about how you would hit the tibial tubercle on something, there's a couple different ways. One would be a dashboard injury. If you're getting a car accident, hit your knee against the dashboard and it pushes the tibia posteriorly. A lot of times you end up with bruising on the front of the tibia, and that should be a clue if they're in a car accident and hit their knee on the dashboard to look for a PCL tear. The other one's just a direct blow to the front of the knee from a fall. So a lot of times, whether in athletic participation or just with a simple trip and fall, the patient falls over and hits their knee directly on the ground. And there's only a couple diagnoses that can be at play if you fall and have like directly land on the knee. One being a PCL tear, the other a patella fracture, and then some things like bone bruises and patellocondral injuries. Outside of that, falling on the front of the knee really doesn't cause any other diagnoses. So if somebody says, I tripped and fell on my knee, that's a kind of a short list of things we should be thinking about. Specifically from signs and symptoms, the patient may have an effusion. They may have bruising in the front of the knee, specifically over the area of the tibial tubercle, along with that kind of history. And then, from a signs perspective, they may have some posterior sag of the tibia. And by that, we mean when you sit with the knee bent at 90 degrees and kind of look from the side, the front of the tibia, the shin bone, seems to kind of sit back in a 90 degree bent position compared to the other side. So a little bit of side to side comparison can usually get to this.
Not just for the listener's sake here, last Patient's Place episode, we talked about degenerative medial meniscus tears, and we talked about the difference between a meniscus tear being more of an acute injury mechanism and then the degenerative type, like we talked about, which is more just that, the name's in the title there, degenerative. It's going to be more of a non-injury over time issue. You talked about two injury mechanisms. Just to be clear, there's no atraumatic PCL injuries. Somebody comes in and says, my knee's been hurting for a long time. You would never suspect anything like a PCL tear, correct?
Well, you could suspect a chronic PCL tear. Now, the mechanism of injury to the PCL does not happen chronically, but a lot of times these patients can present for the first time with a chronic PCL injury because they've injured it and they don't know it. One of the reasons that we see people come in after an injury a couple years down the road complaining of some medial knee pain is a PCL tear. And a giveaway to that is seeing some mild degenerative changes. If somebody says, I have a sore knee, it's been bothering me for quite some time. I had a car accident a couple years back, and ever since then, my knee hasn't really felt right. And you get an x-ray and you find a little bit of mild medial compartment narrowing, that a lot of times is a setting in which the patient may have had a missed PCL tear, either because they went to a provider of some sort and the injury was missed, or because the patient didn't know they had the injury. A lot of times patients will say, I was in a car accident, I hit my knee in front of the dash, my knee hurt for a while, but I was able to get up and walk, I was able to get around okay, it healed relatively quickly, and I felt better, so I never saw anybody about it. And then they'll come in with kind of chronic problems months or even years down the road. So the actual and answer your question, the actual mechanism of injury is not a chronic injury, but the patient can present far down the line with symptoms still related to an injury that to the initial PCL injury.
Now, I'm glad you talked about more of the chronicity of this. When you hear an injury, a lot of times people, the next question is, well, when do I need to go see somebody about this? Is there a timing for this in terms of from the time somebody has that, let's call it the dashboard injury or a fall in the front of the knee and they start developing some symptoms? Is it important for you as an orthopedic surgeon to see this patient right away as it pertains to the PCL, or is it okay if they put it off a little bit?
That's not really necessary with regard to PCL healing. Now, this is talking about an isolated PCL tear as opposed to a multi-ligament injury that has a PCL component of it. That's a totally different thing. Tonight, we're really focusing just on isolated PCL tears. But if a patient has a PCL tear, it's not necessarily a big deal whether the patient comes and sees us right away or later with regard to changing the treatment that we do or changing the ultimate outcome that the patient has. However, if the patient doesn't come in right away, they just may have lingering symptoms for a long period of time. So in that regard, it is good if the patient comes and seeks care for their knee problem right away, so we know we can figure out the diagnosis as quickly as possible, get them on a treatment plan to try to get it taken care of so it doesn't linger any longer than it needs to.
Excellent. Well, let's jump ahead to the once the patient makes the decision to come into the office, what should they expect when they see you? And let's start with more of a physical exam from you. What should they expect after they sustain that injury?
Yeah, so once we've taken that history, then they've told us that they either hit the front of the knee on the dashboard or fell on the front of the knee. Then we start looking for these signs and symptoms on physical exam. A lot of times the patient, if they come in kind of subacutely within the first couple of weeks, will have some swelling. And a lot of times that swelling will develop not necessarily right away after the injury. One of the things that's kind of a hallmark of ACL tears is the patient says, I landed, I felt my knee twist and pop and kind of give out, but then within 30 minutes or an hour, I've noticed that my knee was pretty swollen from the very beginning. I had to come out of the game. It was a big deal injury. And then we start thinking about ACL tears. With PCL tears, it doesn't necessarily happen that way. A lot of times our athletes will fall and have this injury. They'll kind of get up and limp off for a second, shake it out for a couple minutes and still stay in the game. And then the pain and swelling will really show up the next day. And that's something that is another symptom or, set of circumstances that gets me thinking about PCL tears. If the athlete or whoever patient says, I fell directly on my knee, it kind of hurt at first, but it wasn't that big of a deal. But the next morning I got up, my knee was a lot more swollen, a lot more painful. Then I'll start thinking about PCL tears. And then I start looking with a general range of motion evaluation, which I really do for every knee problem that there is. I go to the opposite side. I check their hyperextension and their flexion to kind of set a baseline and then go over to the injured knee. Sometimes PCL tears can have excessive hyperextension. Sometimes you'll see that. So that's another thing. If somebody says I fell on the front of my knee and I go to the uninjured knee and find 2 degrees of hyperextension, I go to the injured knee and find 5 or 6 degrees of hyperextension. That's got me thinking that there may be some sort of posterior injury like a PCL tear. And then from there, we're setting the knee up at 90 degrees and then looking from the side to see whether it looks like the front of the shin is sagging backwards compared to the uninjured side. And then for the more definitively on the diagnosis from physical exams, the posterior drawer. And the posterior drawer, Dr. Shelburne's taught me to do in a different way than maybe I learned to do in residency and fellowship. Most people will tell you to just kind of grab the front of the tibia and push towards the back. Dr. Shelburne's always encouraged me, and I always do the exam this way now, to put my thumbs on the femoral condyles, actually above the joint line, where I can, and then the heels of my hands or my palms on the actual tibia itself below the joint line. And because of that, you can feel the relationship between the tibia and femur at that 90-degree position. And when you push backwards, you can kind of feel the heels of your hand go in posteriorly or towards the back more than the thumbs, which are on the femoral condyles, kind of flatten out that relationship between the heel of the hands and the thumbs, in order to confirm that there's been some change in the relationship of the tibia and femur at that 90-degree position.
How about initially with imaging? What are you looking to get at that initial stage when it comes to imaging?
Anybody who comes in the office saying, I fell on my knee and I hurt myself, we're going to get x-rays on. And our standard imaging for people under the age of 40 would be a 45-degree flexed weight-bearing PA view, a side view called a lateral view, and then some kind of a kneecap view, such as a merchant's view, which is the knee bent at about, I think it's about 30 degrees. We have a merchant's board in our office that the techs will put the knees over that and kind of shoot down from the top to see the kneecap sitting in the groove on the end of the femur, the thigh bone, to assess for patella fractures, to look and see where the kneecap is sitting as far as tracking in the middle of the thigh bone groove that it has there, the trochlea. And usually the x-rays will be pretty normal for people with PCL tears. So from an initial imaging perspective, that's not really a diagnosis that we make by imaging. If we want to confirm the diagnosis after we have done the physical exam and we think they've torn their PCL, MRI scanning is the best one for that confirmation, if that imaging is ultimately needed. Now, the confirmation via imaging with an advanced test like an MRI scan is not necessarily needed with a PCL tear. You may be able to make the diagnosis off a physical exam alone and then not get the MRI scan. But a lot of people want to have it. A lot of, especially higher level athletes, especially if you get coaches and, higher level players involved, they want an MRI scan, even if you tell them that you don't think the diagnosis necessarily warrants that. So sometimes we will cave to that and get an MRI scan. But that's the really confirmatory test that we would need after those initial imaging with plain radiographs.
Now, before we move on to treatment, you mentioned that the x-rays at that initial visit or the x-rays themselves are generally unremarkable. Is that any different when you have a chronic case? Are you expecting to see any type of changes on the x-ray for a chronic PCL versus an acute PCL?
Yeah, we do look at the lateral view to see if you can tell subtle changes in the positioning of the tibia. The tibia will sometimes sit more posteriorly, or that relationship will be different, where the femur is actually sitting a little further forward on the tibia on that lateral view. Sometimes we take our lateral views at a little bit lower degree of flexion, like 45 to 60 degrees, where maybe it wouldn't be quite as pronounced. And even if you take it at that 90 degree, if you take a 90 degree lateral view where you would best see a difference in the relationship if there was a PCL tear, it still can be relatively subtle. It's more of a dynamic problem where we're examining the knee and feeling the knee move in a way that the normal knee does not. But sometimes you can pick that up if the femur tends to sit a little more anterior, a little more towards the front on the tibia on that lateral view.
Excellent. So now you have the patient, you've got the history taken, the physical exam done, the images taken, and you confirm that this is an isolated PCL tear. And I do like the fact that you said that earlier, that tonight we're talking specifically about an isolated PCL tear, because we know that multiple ligament injuries can be treated a little bit differently. But for all intents purposes, tonight we're talking about isolated PCL tears, and you have that diagnosis in the office. What does your next few minutes look like with the patient from an education standpoint? What are you telling this patient?
Well, the good news is that most of these, really all of these in our hands, don't require surgery. And I've been fortunate to be able to learn that from Dr. Shelburne, who's published extensively on this. He won a Houston Award for his paper about non-surgical care of PCL tears that was, for the Journal of Sports Medicine was recognized at the AOSSM annual meeting as the best paper for the year. And in that study, he just looked at the results of a lot of isolated PCL tears that were treated non-operatively, and found good results, that patients were able to do well without surgery. Furthermore, he tried to look at the relationship between how unstable the PCL injury was and whether that had any correlation with the ultimate outcome. And what he found was grading between grade ones, twos, and threes really didn't show any difference, and that sometimes the amount of laxity was actually variable from visit to visit, and the patient's scores kind of went up and down almost independently of the amount of instability there was. So I think most people think if you have a relatively small amount of instability, a grade 1 PCL tear, that patient's more likely to do better with non-surgical care versus if they have a grade 2 or grade 3 instability, that they're probably going to need surgery because their ultimate outcome, if you just let the natural history of a PCL tear play out, will be worse if it's more unstable. And Dr. Shelburne found that was not the case, that really PCL tears of all instabilities can be treated non-surgically. And the reason is the relationship between the femur and tibia is really important. And if you disrupt that by falling on the front of the knee, pushing the tibia posteriorly, that kind of takes the medial meniscus along with it. And the posterior horn of the medial meniscus gets pushed posteriorly as well. And whether it gets pushed a couple of millimeters posteriorly or several millimeters posteriorly doesn't really necessarily change the relative inability of the medial meniscus to do its job as it normally would. Once it's out of position, it doesn't really matter that much how far out of position it is, that the knee is still kind of vulnerable to a little bit worse function, but that the ligament heals and that the knee is still able to be a good knee for the patient in the long term.
What's that healing time look like, and how variable is that? When you said it's, in our hands, it's going to be a non-operative case and the patients can get back to whatever their activity level is without the need for a surgery. Is there a time frame that you're typically telling these patients? And I know it's hard in the initial visit, but as you know, you get those questions a lot day one. It's how long am I going to be out of work or out of my job or out of my sport, those types of things.
Yeah, this is where the grading really does actually make a difference in what we prognosticate for the patient. Not what's my ultimate outcome going to be based on the grading, because Dr. Shelburne found in multiple studies that it's about the same. But instead, what is my predicted return to sport? And that's where the grading does seem to make a difference. So if the PCL has less than 5 millimeters of laxity where it does not push back flush with the femur, that should be a shorter return to play versus grade 2 where it's flush with the femur, or grade 3 where it's actually, you can push it posterior to the femur. Those different grades of laxity can make a difference with regard to return to play. In general terms, in my opinion, a PCL tear is a day-to-day injury. Once you have enough stability and range of motion and strength that you can go through a functional progression and return to activity, it doesn't matter to me whether it's been 3 days or 3 weeks or 3 months. If once you get to the point where functionally you can do that, you can return to play, because the PCL ultimately will heal on its own radiographically. We just got to get the knee functionally better. However, a larger grade PCL tear will take longer to get better. So usually for people with a grade 1 tear, I'll tell them that it's kind of day to day, but can take about 2 to 4 weeks. When we get to grade 2, I say more like 4 to 6 weeks. And then when it gets to grade 3, it's more like 6 to 8 weeks. So the patients can have a little bit of an idea on how long things are going to take. But if a grade 2 patient comes back after a week saying, I have all my motion back, my knee feels good, I went through a functional progression, the swelling's not bad, I want to go back and play, then we would allow them to play. In the same way, if a grade 1 PCL tear got to that 4-week mark and said, I still just don't feel right, I just don't feel like I can go play, we wouldn't say, too bad, it's healed, you got to go back. Not at all. You kind of have to get the knee ready from a criteria-driven rehabilitation where you have to get full motion, good strength, progression through a functional challenge of getting back into sport, and whatever time frame that happens, they can return.
Now, when you mentioned that this injury is more of a day-to-day timeline for return, what are you worried about from a structural standpoint? Are you worried about the patient going back and re-injuring a PCL that's trying to heal, or are there secondary injuries like chondral injuries or meniscus tears that you're worried about?
Not really either of those. I don't worry about them continuing to tear the PCL worse. They could, of course, fall on the front of the knee again and hurt it, but that's true whether they do it right after injury or whether they do it after it's healed. It could be re-injured. But it's really just about them being functionally able to play sports. We always want to put people back into sport at a time when they're less likely to re-injure themselves. And I think if we put athletes back on the field with differences in range of motion, differences in strength, differences in confidence, and without a good progression from light activity to heavier activity to sport-specific activity to competition, then we're potentially doing them a disservice. So I do think it's important to not put people back before they're functionally ready, so you don't put them at risk of injuring something else or just not being effective and not being able to do the things that they want to do.
Now, when it comes to re-injury, especially in athletics, so there's some injuries, like lateral ankle sprains or patellar dislocations where you do it once, you're at higher risk for a second, you do it a second time, you're at higher risk for a third, those types of things. Is your fear of that with PCLs at all? Or when you get somebody they tell you, hey, Dr. Benner, I'm 100% back, I'm back to my sport, I've been playing for 6 months. Are they pretty much back to baseline when it comes to a re-injury risk for PCLs?
Yeah, the short answer is yes, that they're essentially back to baseline risk for re-injuring their PCL. I've had maybe one or two people that have fell on the front of the knee and kind of tweaked the PCL and injured it again, but it doesn't necessarily set them back. It's not like a patella dislocation, like a lateral ankle sprain, like shoulder subluxations, things like that you mentioned, where every time it happens, it's more likely to happen again. In all those situations, if you develop chronic instability, then that could lead to the point where it gets so unstable that you're vulnerable to continued injury, and we need to go ahead with surgery. And that really doesn't happen in our hands with PCL tears.
Now, before we wrap up here tonight, when you mentioned that the course of treatment is non-operative treatment, and I know in our office and in meetings and such, we like to discuss that non-operative treatment is just not telling the patient they're not having surgery. There has to be something else to offer the patient. Could you just briefly go through what that treatment may entail and what the patient would expect for non-operative treatment?
Yeah, it's a big difference between saying that there's no surgery versus saying there's no treatment. We don't operate on these people, but we absolutely treat these patients in that, as we talked about, if you don't do things to try to help the knee get back to normal early on after an injury, it can just linger and turn into a chronic injury. So if we take somebody that has a relatively minor PCL injury and we just tell them you'll be back in a few weeks, just wait till it feels okay and then go back to activity, they'll do that. But the chances of them not being able to feel like they're 100% is much, much more, versus if we say, well, this is going to heal on its own. It's going to heal and function pretty well in the long term. And we say, in the meantime, while it's healing, we got to get your motion back, get your swelling down, get your strength back, get your confidence back, progress through a sport-specific progression before we get back to competition. That's a much more likely thing to make sure the patient doesn't turn into the patient's knee doesn't turn into a longer-term problem. We definitely see patients that come and say, I had a car accident, I hit my knee against the dash, didn't think it was that big of a deal, but the next day it was really swollen, and over the next 3 or 4 weeks, it gradually got better and I got back to doing activities. But then they'll say, I've never really felt like this knee is the same. And when we examine the knee, most of the time in those patients who still don't feel like they're the same, it's not necessarily the PCL laxity that is the problem, even if it's present. The PCL does heal in a lengthened position, so you will be able to get a little more laxity with that posterior drawer in the long term. However, when those patients come back with kind of continued lingering problems from a PCL tear, it's usually due to stiffness and weakness. So when we take those patients to the therapy department, have our therapist see them, they'll have a 3 to 5 degree flexion contracture. They'll be down 5 to 10 degrees on flexion. When we measure their Cybex and leg press strength testing side to side, they'll be down by 30, 40, 50% compared to the normal side. And they'll say, well, I was told, after a month that my knee was fine. I got back to playing and then I was done and I didn't really get any treatment for it. So instead of that, we like to have really the same kind of progression that we do for any knee injury. How we want to get the swelling down, we want to get the extension back first. Once the extension's better, we want to maintain that and progress flexion. Once the flexion's back to normal, then we want to start light activity, biking, elliptical, Stairmaster, swimming, stuff like that. Gradually increase that until we can test our strength and get a baseline side-to-side strength assessment, and then start working on single leg strengthening until the injured knee gets back up to where the opposite knee is, and then let the patient start doing a progression back to sport and eventually return to full sports. That's the progression for us for PCL tears, for ACL tears, for total knees, for revision total knees, for scopes, for non-surgical treatment, really for everything we do. It just progresses depending on the injury, much differently. Sometimes it's a few days before that whole process plays out. Sometimes it's several months in a post-operative recovery before it's back to normal. But for PCL tears, again, no surgery doesn't mean no treatment. We do need to rehabilitate your knee, make sure you get back to full motion, full strength, full function, so this doesn't turn out to be a bigger problem than it needs to be.
Now, throughout this episode, you have mentioned that this is, in our hands, going to be a non-operative case, and we're not recommending any type of surgery. But that's not to say that surgery for PCL tears does not exist. So,
yeah.
Can you touch on the surgical procedure for when some surgeons do choose to operate on these, and why would you choose not to?
Yeah. Well, it's interesting to contrast these with ACL tears. So first of all, do PCL tears reliably radiographically heal? The answer is yes. Even if they heal with a little bit of laxity, they do reliably heal radiographically versus an ACL tear. If you take an MRI scan several months down the road, the ACL doesn't heal, or doesn't heal predictably and reliably. So that's one major difference. The second one is, does it cause recurrent instability? If you don't fix a PCL tear, but rehab it properly and get the patient back to full activity, will they have recurrent giving way episodes? And the answer for PCL tears is no. They usually will not have symptomatic instability after the ligament has healed and they have rehabilitated, versus an ACL tear. If you don't fix it, then patients get back to rehab from the initial injury and they get back to sport, then they'll have recurrent instability. Next, does it improve the stability to do a reconstruction if you end up going to surgery? And does that lead to a decrease in symptomatic instability? For ACL tears in particular, get KT testing, arthrometer testing. With ACL tears, it will go from several millimeters of instability and the patient having symptomatic giving way episodes to much less instability on the functional testing or on the stability testing, and the patient not having those symptoms. So we are able to restore stability as close as we can to the uninjured state, and that those patients do then get back to sports without feeling like their knee's loose. With PCL tears, on the other hand, though, if you measure laxity on PCL tears, if you try to look at the relationship between the femur and tibia, there are studies that have shown that you can decrease PCL laxity radiographically or in restore some stability, but it doesn't get back to normal. And as Dr. Shelburne has kind of shown with his non-surgical natural history studies of PCL tears, that if you have a little bit of instability or a lot of instability, that it doesn't seem to matter for your outcomes. If we're trying to restore stability that we've shown with natural history doesn't actually matter, then we're restoring something that we don't necessarily need. So after putting all those together in my head, I think for ACL tears, it does cause symptomatic instability. It doesn't heal radiographically. The patient does have repeated giving way episodes. A reconstruction can restore stability and decrease the amount of instability that there is, and that the symptomatic instability can go away. For PCL tears, on the other hand, it does reliably heal radiographically. It's not really a difference if there's instability as far as symptoms for the patient. If you reconstruct it, it doesn't necessarily get you back to full stability. And even if it does, it doesn't necessarily matter with regard to your outcome on the natural history study. So that, is kind of divergent between ACL tears and PCL tears. That in my mind means that ACL tears need reconstruction and restoration of stability, whereas PCL tears in an isolated manner at least do not.
So just quickly before we wrap up, I want to touch on just one more thing. This whole time we've been talking about this injury as an isolated PCL tear. Just quickly, how does this treatment differ, whether it goes from a non-operative case to an operative case or whatever? Are there any differences on how you approach a PCL tear when it's torn in conjunction with other ligaments?
Yeah, there's no doubt that the kind of state of that knee is much different if there are other ligaments involved as well. However, Dr. Shelburne has also shown in those same PCL studies that even if they're combined with other ligament instabilities, that it doesn't need to be reconstructed, and you can still get good outcomes from multi-ligament injuries that include the PCL. So specifically, you can check out, if you want to check out our previous content on multiple ligament injuries, we've got a couple episodes alluding to that. But just in general, we believe that lateral side injuries need to be repaired. ACL injuries need to be reconstructed. Medial side injuries can be immobilized and gotten to heal and treated non-surgically, and that PCL tears can be treated with rehabilitation and can heal on their own. So if the PCL is involved in a multi-ligament injury, we still believe that this PCL can heal as part of a more comprehensive and stepwise algorithm that we've detailed in other episodes of the podcast that people are welcome to check out.
Excellent. Well, as always, thanks again for going over that. I love these Patient's Place episodes. It really gives some great insight, especially from your perspective as the one that's seen and diagnosing and eventually treating these patients. So just a reminder for all the patients out there, you can contact us on our social media pages for more information on these episodes. You can contact us at the SKC Podcast on Twitter and Instagram, as well as visit our SKC YouTube and Facebook pages, or email us at the SKC Podcast at gmail.com.
As always, our Patient's Place episodes are for educational and learning purposes only. If you have any specific questions about your care, we encourage you to reach out to your surgeon for more information.